You noticed it at the end of the day. Your ankles looked puffy. Your socks left a ring around your leg that took a while to disappear. You pressed your finger into the skin above your ankle, and the dent stayed there for a few seconds before slowly filling back in. You blamed the flight, the long day on your feet, the salt in last night's dinner. You went to bed, woke up, and it was gone. So you stopped thinking about it. But it came back, and it keeps coming back. What most people do not know is that ankles are where the kidneys send their first visible distress signal. Not pain, not blood in the urine, not any of the dramatic signs people associate with kidney disease. Swollen ankles, the kind that appear by evening, that pit when you press them, that disappear overnight only to return the next day, are frequently the first physical sign that the kidneys are losing their ability to regulate fluid in the body. By the time the swelling is visible and consistent, the kidney function behind it has often been declining for months, sometimes years. To understand why swelling starts in the ankles, you have to understand what the kidneys actually do with fluid. The kidneys filter approximately 200 liters of blood every day. They regulate how much water and sodium the body retains, they maintain the pressure balance between the bloodstream and surrounding tissue, and they produce a protein called albumin, indirectly, by regulating the liver's output, that acts as the blood's osmotic anchor. Albumin is what keeps fluid inside blood vessels, rather than leaking out into surrounding tissue. It creates an osmotic pull that holds water in the circulation. When the kidneys are damaged, two things happen simultaneously that both produce fluid leakage. First, the kidneys lose their ability to excrete sodium efficiently. Sodium draws water with it wherever it goes. When sodium accumulates in the blood, water follows, increasing total fluid volume in the circulation. That excess fluid has to go somewhere. Under the influence of gravity, it goes down, to the feet and ankles. Second, kidney disease causes protein to leak through the damaged glomerular filters into the urine. As protein leaves the blood, albumin levels fall. The osmotic anchor weakens. Fluid seeps out of blood vessels into surrounding tissue. Again, pooling in the lowest point of the body, the ankles. This combination, sodium retention and falling albumin from protein loss, is why ankle swelling is not just a kidney symptom. It is a specific, physiologically coherent sign of glomerular damage, and it appears at a stage when blood tests may still look relatively normal. The swelling has a specific character that distinguishes kidney-related edema from other causes. It is pitting edema. Press your finger firmly into the skin above the inner ankle bone for 5 seconds and release. If the indentation remains visible for more than a few seconds before refilling, that is pitting edema. The dent persists because the tissue is waterlogged rather than inflamed or fatty. The fluid is interstitial, sitting between cells in the tissue, not inside the cells themselves. This distinction matters for diagnosis, and the pitting test is something anyone can perform at home. Kidney-related ankle swelling follows a daily pattern. It is minimal or absent in the morning after a night of lying flat, because gravity is no longer pulling fluid downward, and the body redistributes it during sleep. It builds through the day as the person is upright. By evening, it is at its worst. This morning-to-evening progression is consistent enough that its absence, swelling that is equally present in the morning as in the evening, suggests a different cause. The swelling is also bilateral, both ankles, both legs, at the same time. One leg swelling, particularly if accompanied by warmth and redness, points toward a clot in the deep venous system and requires urgent evaluation. Kidney-related edema distributes symmetrically because the underlying problem is systemic. The entire circulatory system is under-filtering, not one regional vessel. What makes this symptom so easy to dismiss is that ankle swelling has many causes, and most of them are benign. Sitting for long periods, flying, standing all day, eating a high-sodium meal, heat, certain blood pressure medications, particularly calcium channel blockers. Venous insufficiency, the most common cause of chronic ankle swelling overall, produced by failing valves in the leg veins that allow blood to pool. The problem is that the same symptom produced by a long flight and the same symptom produced by early kidney disease look almost identical from the outside. Both pit, both follow gravity, both ease overnight. The distinction lies in the pattern over time. Swelling that appeared once after a specific trigger, a long journey, a salty meal, unusual heat, and resolved and did not return, is almost certainly benign. Swelling that comes back consistently, that has been present on most evenings for weeks or months, that seems to be getting slightly worse over time, that cannot be fully attributed to any specific trigger. That pattern is the kidneys pattern. Two other features push the probability toward kidney disease. The first is swelling that extends above the ankles, into the calves, the shins, and eventually the thighs, as the underlying condition progresses. The second is swelling around the eyes in the morning. Periorbital edema, puffiness around the eyes on waking, is a sign of systemic low albumin and is a particularly specific marker of significant protein loss through the kidneys. Most people attribute it to poor sleep or allergies. When it appears alongside ankle swelling that follows the evening pattern, the combination is a strong signal that the kidneys are involved. There is a test that costs almost nothing and can detect kidney disease years before symptoms become unmistakable. A urine dipstick for protein. A standard urinalysis, the kind ordered at routine health checks, includes a protein result. Trace or negative protein is normal. Persistent protein in the urine, protein that appears on 2 or more tests separated by weeks, is the earliest laboratory sign of kidney damage. The glomerular filter is leaking. It is allowing protein to pass through that should be retained. This leakage, called proteinuria, precedes the ankle swelling in most cases. The protein is leaving the blood before the albumin level falls far enough to produce visible edema, which means that if ankle swelling has already appeared, the kidney damage behind it has been present long enough for significant protein loss to have occurred. The swelling is a late signal of a process that the urine could have detected earlier. Foamy urine is the visual correlate of proteinuria. Protein in the urine creates surface tension, the same phenomenon that makes soap foam. Urine that produces persistent froth or foam that does not dissipate within a minute or two is protein-rich. It is not always present, and it is not always noticed. But when it has been observed in the weeks or months before ankle swelling appeared, the sequence is telling a clear story. The kidneys most associated with this specific presentation, ankle swelling driven by protein loss, are the glomerular diseases. The glomeruli are the kidney's individual filtering units, tiny capillary networks wrapped in a membrane designed to retain protein while allowing waste to pass. When the glomerular membrane is damaged, it becomes permeable to protein. The two most common glomerular diseases that produce significant proteinuria, and the swelling pattern described here, are diabetic nephropathy and membranous nephropathy. Diabetic nephropathy, kidney damage from chronic elevated blood sugar, is the single most common cause of kidney disease worldwide. It begins silently with microalbuminuria, small amounts of albumin in the urine detectable only on specific testing, which progresses over years to macroproteinuria, and eventually the full picture of nephrotic syndrome, which includes severe edema, low albumin, high cholesterol, and heavy proteinuria. The ankle swelling typically appears in the macroproteinuria phase, by which point the diabetes has usually been present and impacting the kidneys for a decade or more. Membranous nephropathy is less well known but significant. It is the most common cause of nephrotic syndrome in adults over 40, and it can appear without any prior kidney disease, diabetes, or known risk factors. It is an autoimmune condition in which antibodies attack the glomerular membrane directly. In 2009, researchers identified the primary target, a protein called PLA2R, which has transformed both diagnosis and monitoring of the condition. Many people with membranous nephropathy present first with ankle swelling and are investigated backward to the kidney. The ankle is where they noticed something was wrong. The kidney is where the problem was. Ankle swelling that is new, bilateral, pitting, worse by evening, better in the morning, and has been consistently present for more than 2 or 3 weeks without a clear benign explanation, deserves a urine protein test and a blood creatinine level before it is dismissed. These two tests together, urine for protein, blood for creatinine, provide a direct view of kidney filtering function and glomerular integrity. They are part of any basic metabolic panel and urinalysis. They do not require a specialist to order. They require a doctor willing to consider the kidney when the ankle is what the patient brought up. The problem is that ankle swelling is rarely greeted with kidney disease as the first hypothesis. It is greeted with compression stockings, dietary sodium advice, and a suggestion to elevate the legs in the evening, all of which help the symptom, none of which investigate the cause. Legs elevated. Socks left off in the evening to relieve the tightness. Pressing the finger into the ankle before bed to see if the dent is worse than yesterday. These have become the routine. They did not need to. Pitting edema in the ankles, bilateral, consistent, following the evening pattern, is a kidney symptom until proven otherwise. The test that proves otherwise takes 1 blood draw and 1 urine sample.